a monthly meeting webinar on behalf of IFS South Tamilnadu chapter. Can I have the prayer song, please?
கருவாக்கி உருவாக்கி எனையாண்டு காத்தருளும் இறைவா நன்றி. எங்கும் நிறைந்தோனே எல்லை இலாதானே, எங்கேயும் எப்போதும் என் குலம் காப்பவனே. நெஞ்சம் துணிய துணையாய் வருவாய், நேர்மறை உணர்வுகள் பெருகிடச் செய்வாய். உடலில் உறுதியை பெரிதாய் தருவாய், உனை உணரும் அறிவை என்னுள்ளருள்வாய். சுற்றமனைத்தும் காப்பவனே, செய்தொழிலில் ஏற்றம் தருபவனே, எடுத்த செயலில் வெற்றி கொடு, என் ஆற்றல் பெருகிட அருளை கொடு.
Thank you. I request Ramni to welcome. Dr. Ramni is the patron of this chapter, and I request Dr. Ramni to welcome the gathering and the speakers as well.
Good evening, everybody. See, it is my pleasure to welcome all of you for the IFS South Tamilnadu monthly meeting that is being started just now. And we have two great speakers for the day today, and the important topic is surgical management, conservative surgical management in infertility patients, and ultrasonogram in infertility. So those two topics, I think they are very important, because now the incidence of sterility is, infertility is also on the increase, and most of the women, they get married at a later stage, and they come to us with fibroids or pelvic inflammation, addition, and so many endometriosis, etc. So, and not for all patients, we can go for ART. But there is a good role for properly done laparoscopic surgical management for fertility. So that is like, for example, like you can go for a myomectomy, go for a restoring the tubal anatomy and restoring the pelvic anatomy in endometriosis patients, and bilateral tubal block, and hysteroscopically, so many things, Asherman syndrome, septal dissection, submucous myoma, n number you say that it can be done today by laparoscopy. So we have a good speaker with us, Dr. Lavanya Kiran. She is from Kaveri Hospitals, Bengaluru. She is both laparoscopic as well as a robotic surgeon. And the next speaker is Dr. Sridevi from our own place, who is a senior ultrasonologist. And her interest towards infertility and ultrasonogram is quite extensive. And hence, she'll be sharing with us what will be how we should proceed with ultrasonogram in infertility patients, and what are the important things we have to get it from them. And follicular monitoring, now we have so much of additions to the follicular monitoring. Simply, previously we used to say the endometrial thickening and just the follicle size, that's all. But now we know that the blood flow and the Doppler study, everything matters a lot. And the 3D is also gaining more of importance, so that we can exactly measure the volume of the endometrium, so that it can be helpful to us in going in for an simple IUI or IVF. So can you share the CV of Dr. Lavanya?
Before that, I need to give my secretary report of last month.
Okay.
So we had the CME last time. We were a little late because of the TNFOG. Yes. I couldn't do it in the last week of April. So we had it on 1st of May. That was on, the topic was the poor ovarian response, dilemma in ART. So we had one speaker from Trichy, Dr. Sitara, who gave us a vivid thing about classification of understanding about poor ovarian reserve. She spoke about definition, classification, and diagnostic challenges related to poor ovarian reserve. Then we had an experienced doctor who told to us about, that was Dr. Kritika from Simar Cochin. She told us about optimizing ovarian stimulation protocols in poor ovarian reserve and what would be the best protocol that you would choose for them. So again, we had about 45 attendees for that meeting and a good discussion following the meeting. So that was the last meeting's episode. Now we are looking forward for this month, and we are looking forward for these two speakers who tell us about the two eyes, which are very important for us to diagnose anything related to infertility. This history can be about diagnosis with ultrasound, so that will help us to counsel them better and what would we expect on laparoscopy and how we can correct with laparoscopy these things so that we get a better outcome for their infertility. Thank you, and over to you, Ramani, to introduce Dr. Lavanya. Dr. Lavanya CV, please. Sahiti.
Lavanya CV, please.
I have it.
Yes, ma'am. Yes, ma'am. I'm sharing.
Yeah.
A smart looking
if I am going to read Dr. Lavanya's CV, the entire time will be going on. See, apart from her fellowship in reproductive medicine, it is nice to see that she has obtained a MBA in hospital management and PGD MLE, and which is going to be, we need that as all practicing consultants. And she is also a robotic surgeon from Kaveri Hospital, Bangalore, and awards, Big Impact Award, Innovation and Innovators Award, Kempakauda Award, and Bala Gangadharanath Swamiji Samajya Seva Award.
I think we will let it be. I think my achievements are very small in front of all your achievements.
No, not at all. See, as well as Asia GCC, Foxy Award for contribution to OBGYN, awarded as a surgeon in the least learning curve for robotic surgery, and Chairman's Award for distinguished services, doctors at Narayana Health, and invited by many overseas universities, as well as she has been like a speaker in all national and international program, and she has authored many chapters in the textbook, as well as she is currently the Vice President of Karnataka chapter of ISAR and Honorary General Secretary IASRM, and so many achievements for so many societies. She has been one of the important office bearers. So she is also trained in stem cell regenerative medicine from Romania Society, trained in robotic from Kochi, Amarthanandamaya, and then trained in aesthetic gynecology, oocyte tissue preservation, and trained in obstetric ultrasound and laparoscopy and hysteroscopic surgery. I think she has nothing left behind in OBGYN. She has been trained master for all subjects in OBGYN. Over to Dr. Lavanya. We are eagerly waiting to see your fantastic videos on the laparoscopic surgery, what you are going to project now. Thank you. Thank you for accepting our invitation and coming over here. Thank you.
Thank you, Ramani ma'am, for that wonderful introduction. At the offset, I would like to thank IFS, Pankaj sir, Professor Shweta madam, Ramani madam, and Chitra madam specially for choosing me for this talk. And I think it's a great honor. I was telling that IFS is doing such a wonderful job, and Tamilnadu per se, I think all societies do really great job. And I love the academic programs, the topics that you people choose, and really good. Thank you so much. And let me share my slides. And like I mentioned, I think what you people have achieved is much more bigger than what I am talking about. So today I'll be talking about robotic surgeries, and because basically we all know of how I would say, let me try to get this on the slide more. Yeah. So this is a big good evening from my robotic team, and I'll be talking to you all about role of minimal invasive surgery in infertility. I think we all understand infertility. We have so many issues which comes up. so much of modalities of treatment which is going on. Unfortunately, a lot of our fertility patients end up having a lot of pathologies. And these pathologies cannot be treated only medically. They will need a surgical intervention. And these surgical interventions have to be fertility enhancing kind of a surgery. And these should be helping us achieve a end pregnancy result. That is the pregnancy result, which is most important. And for this, I always say curiosity is the mother of invention. Only when we are curious, we will be ending up looking into different modalities of treatment of how we can help our fertility patients to achieve pregnancy rates better. I think we all agree that AI has entered into healthcare like a carcinoma, where machine learning, advanced analyticals, tangible solutions, treatment modalities of planning for patients, patient engagement, even from the time they have entered the OPD to the quality of care, everything AI has been there. We talk about medical imaging, the drug discovery, the personalized medicine, the health records per se, the outbreak predictions, the trials, everywhere the AI is there. And it has taken an extraordinary feat where it helps in improving the patient's care on day-to-day basis. As a human being, I think the body needs a lot of visualization, the diagnosis, the treatment modalities, where we have to understand smallest thing like blood sugar to making a patient who is paraplegic or quadriplegic by wearable devices, and robots have done these things. There have been flexible arms from neurosurgical robots making people walk who couldn't have walked. And this is how there has been evolution of laparoscopy and robotic surgeries. Different generations have happened from first generation, second generation to fourth generation. Robotics has reached fifth generation. How did minimal invasive surgery start off? So in 1940, colposcopy was the first thing used as a visualization tool. And in 1963, Clement introduced tubal sterilization through laparoscopy. The first laparoscopic hysterectomy was done in 1989. It's not too long ago by Richard Letard. So imagine where have we progressed. If we look into our statistics, we see that the worldwide there has been a high procedure of hysterectomies which has increased drastically from minimum of 10,000 to 30,000 and 5,000. Every year there has been an exponential growth. And here we talk about minimal invasive surgeries, be it laparoscopy. Since my heart and my passion is towards robotic surgery, I'll be addressing about robotic surgery, but it's the same when it comes to laparoscopy also. And I will tell you what is the differences between laparoscopy and robotic surgery. We as surgeons have adopted minimal invasive surgery because of its great surgical precision, safety of the surgeries, and patients have been able to resume to their work, resume to their families, and have been able to be on their foot with lesser complications compared to open surgeries. And this is what we want for our patients as well in infertility patients. And over 30 years, I think that has made a lot of difference. Now, when we talk about why did the world move into laparoscopic surgeries or robotic surgery, basically the minimal invasive surgery, we can see how large incisions have been used in the abdomen. If you date back and if we ask Chitra madam and Ramani madam, they will say when they were postgraduates, they saw vertical incisions. And now in our generations, we have been seeing a lot of transverse incision. But we know what is the morbidity the patient faces, what all problems they go through. And this is how the world has transited into smaller incisions. Now from smaller incisions, world is entering into single port incisions. There are already single port laparoscopic surgeries. Very soon, even robotic will be done with single ports, where the trial has been happening in the US. And this is how we have advanced from surgeons standing and operating for hours together to lesser invasive surgeries, and now surgeons sitting and operating. But when I say world has moved into robotic surgery, are we trying to say that latest is the best, newer technologies has got the greatest benefits? Does it mean novelty is equated to benefit? Definitely not. I think I always say that we should not stop questioning when we talk about any newer modalities of treatment. We have to see what is the credential medical evidence which is there, and does this have equal benefits to our patients. So this is why we have to first answer why robotic surgeries. A little bit brief history about robotic surgery. In 1980s and 90s, the NASA and defense people, there were a lot of wars going on. There were a lot of soldiers in the battlefield where people were scared to go and operate on these people. That is when the robotic surgery came into field in 1995. Intuitive was there. First, Da Vinci was introduced in 1999. 2000, we had the FDA approved for the first robotic surgery. In gynec, it was in 2005, where a surgery for a soldier in the war field could be done by a surgeon sitting at a distance, and so that the doctor's life was more preserved and could have happened. And robotics has changed to a greater extent from 1985. Different systems have come in. We have more than 5 or 6 different kind of robotic surgeries which is there. We all understand and agree with the laparoscopic surgery. We have very less blood loss, better post-operative pain scores. We have early bowel resumption, lesser operative time, reduced hospital stay, lesser blood transfusion, addition formations were lesser, resumption to work is better. When all these things were already there in laparoscopic surgery, what is so good about robotic? Why do we have to shift from laparoscopy to robotic surgery? Even then, what did I say? Even though we have a highest technology, we should never stop questioning. And what are the questions we need to ask? We need to ask any minimal invasive surgery, be it laparoscopy or robotic surgery. Is this technique feasible for my infertility patient? Is it safe? Is it equivalent to an open surgery? Is it equivalent and giving the end point results as much as the open surgery would do? Is there any specific advantages? Is there a cost effectiveness? And what is the outcome? Are we achieving the same? If we answer this, I think we definitely know what is the right modality of our treatment, which we are offering to our patients, where I feel we have to still make our ethics. And be it the minimal invasive surgery or open surgery, I think anatomy is something very, very important for all of us to be really good. And that is when we cause lesser complications to our patients, and very important to know our surface anatomy as well. Especially when it comes to minimal invasive surgery, these are the ports that we are going to put. It is just that in robotic surgery, the arms are a little above. So we have to understand where is the aorta coming, how do we go? So the ports are placed a little above. So this is how the entry is made. I always say abdomen is a Pandora box, especially in infertility patients. We know at least we have 30-40% of the patients who have adenomyosis, endometriosis, and quite a severe endometriosis. And especially by the time patients come to a fertility doctor, they would have already gone through some laparoscopic surgeries. So a lot of additions are there. That is when today morning only I got a patient who had done the laparoscopic surgery for endometriosis grade 3. They had converted because lot of additions. And she's coming to me for her second surgery because she again has a bigger mass of 9 centimeters, still not conceived, and they want to do a robotic surgery. So how will I help her through a robotic surgery? Let's understand a little bit of robotic surgery. You can see the screen where we have a patient card, we have a surgical console, and we have a vision card. This is how we'll have problems entering, and I wish all we fertility specialists, when we operate our patients, it is going to be as clear as this and we can give end results. But that is not so. When we go in, we see a lot of additions, blood-filled fluid, blood-filled field where we cannot see any organ, and very difficult to operate as well. And these are the kind of pictures we will see in patients with cyst formations, and we don't know where to start, where to end, because where do we go? So always try to go from the unknown to the known regions, and that's the crux of a beautiful surgery. So we have blood field, field like this where we don't know where to operate. So much of additions, where do we start? Especially in myomectomy surgeries, the bleeding is so much more. And ureter, is all gynecologist friends, where any injury, we are all panicked. Even before an injury happens, we are all trying to be very careful. I've almost become a urologist through our hysteroscope. At the end of any difficult procedure, I try to do a cystoscopy. I use my hysteroscope to do a cystoscopy and see that jutting happening and makes me feel better. When we talk about the patient card, the advantage here is in laparoscopy, you need to have assistants. People, whoever is doing laparoscopic surgeries here will understand of how difficult when the camera person is not showing you well, when the assistant is not holding well. And especially in cases like myomectomy, endometriosis, the assistant is also going to get tired. Advantage in robotic surgery, every arm is held by this robot. So there is no difference in the focus or in assisting because all these ports are under the surgeon's control. They have 3 arms, 4 arms. So you can use 2 machines, 3 machines, 3 surgical instruments at the same time without compromising anything. They have advanced technologies like endorist vessel sealers where bleeding is going to be less. They have staplers. Of course, these are also there in laparoscopic surgeries. Let's see if my luck works and my robotic surgery videos play. You can see here, assistants have hardly any role. This is where the patient bed is, operating table, where you hardly see there is no assistant standing. There's only one technician standing there and he's busy doing his own work. And you can see all these arms moving where, you can see that, everything happening by itself because the surgeon himself is trying to move the instrument and it is very easy for us. And that is the advantage. Imagine you have a port and then you did an ultrasound. Unless we have somebody like Sridevi madam who is very well versed in scanning, you do a scan, you think it's a small fibroid, there is one fibroid, and you go inside doing a laparoscopic surgery, you see a big mass sitting there. How are we going to help? Because imagine in laparoscopy, you're trying to do this, try to cut, do the suturing. Doing a myomectomy is not the greatest skill, but doing the suturing for this kind of a big myoma is where we have a problem. Now you can see another picture where we have multiple fibroids and you don't know where is the uterus starting, where is it ending. So these kind of places we have again trouble. So imagine these are all 3 kg, 2.5 kg, 3.5 kg fibroids and very difficult, especially because in our infertility patients, we need to make sure that the cavity is not entered. Our suturing is so appropriate so that we can help her conceive early and we give her a term pregnancy and we are not going to end up with a rupture should be our end results. All these things are very well achieved through robotic surgery because our vision card is so good. We have a 3D in the vision card where of course even now the advanced laparoscopies have 3D vision. The instruments have endorist movement. That means the tip of the instrument, unlike laparoscopy, which is only horizontal or vertical 90-degree movement, endorist movement, it is 570-degree movement. Imagine our hand rotates 360 degrees. So imagine in a robotic surgery, I'm saying 570-degree. So imagine the flexibility we are going to get when we do a suturing, and the ergonomics are so good. The touchpad, the stereo view, the master controls are excellent, and this is why we have a better outcome for our patients and without any strain to our co-assistants and everything under the control of the surgeon. And that is how it is best with all these advanced technologies. Another advantage is the firefly technology, especially when we are doing conservative surgery. Now we have a lot of cancer patients. We have patients where we have to do conservative surgery for these cancer patients so that they can plan their pregnancy. That is when we have firefly technology, which is going to be helpful. This was one of the patients where we had to do a lymph node resection and we wanted to plan a pregnancy for her. Since we don't have firefly technology, we don't know where is the lymph node, where is the ureter, what is happening. Can you see when we switch off the color, how beautifully, you don't know. But when you switch on the color, you know where is the lymph node, what is happening. And these are the kind of changes which has happened through a robotic SI system and an XI, and this is how it has been there. And so as my transition happened from SI, XI, and today I operate on the 5th generation robotics. Like Madam mentioned, I have the least learning curve because in 9 days we had done 11 surgeries as soon as my training was over. I've been a TEDx speaker for the same for robotic. I have written chapters And we know as surgeons, we are all explorers. So I've explored CMR, SSI, Mantra. So I'm the very few surgeons who is trained in all robotic consoles, which is available and certified for the same as well. So this is my beautiful team. When I talk about so many advantages of robotic surgery, we have to see what Dr. Lavanya is telling. It is so useful for the surgeon. It is easy to operate, lesser assistance, better clarity, better 3D vision. Are we trying to see, does it have a value for our patients? Definitely yes. To start off, our incisions are much lesser. Be it laparoscopy or robotic surgery, we need to understand there is no more vertical scars. Doesn't matter how big the fibroids are. We have operated patients who are uteruses are more than 24 and 26 size in laparoscopy and robotic surgeries. So incision sizes are much lesser, smaller incisions, and this is how patients are much better in long-term health when it comes to even endometriosis, because now the newer data says 1 in 4 patients have fibroids. At least 80% of the patients have endometriosis, mild and major, and we have pelvic prolapses. So how do we help these patients to conceive? So the long-term health is definitely through minimal invasive surgery, and a lot of hormonal surgery. Hormones we give also 90% will be working through surgical methods as well. So in robotic, like I mentioned, 7-degree freedom movement, 3D vision, lesser hospital stay, all arms are controlled by the surgeon, lesser blood flow, and firefly technology. Clinically, do we have, when we are saying patients is validated, clinically is it validated? Yes, it has been there, used by so many urologists, gynecologists, general surgeons. You can see the number of indications where minimal invasive surgeries has always been there. These are the journals supporting laparoscopy and robotic surgery for myomectomies, where we have lesser blood loss, lesser hemoglobin drop, shorter hospital stay. Even bigger myomas can be removed by laparoscopy and robotic surgeries. Now, being fascinated with myomectomy, I think suturing is the best and easiest when we compare to a laparoscopy and robotic surgery, especially when we have bigger things, because of its movement in the robotic surgery, and fertility outcomes are better. So I was laparoscopic surgeon for more than a decade, and that is how robotic came into my life. So I was fascinated, did a study on this. We have an international publication, and this is from the same study that I'm presenting. We had done 13 patients for robotic surgery and 11 for laparoscopic surgery. And you can see when we compared laparoscopic and robotic surgery, the abdominal surgery conversions were not there at all in robotic surgery. Few patients we converted in laparoscopic because of the bleeding. Indications were majorly in infertility patients, dysmenorrhea, menorrhagia, pressure symptoms. And fibroids were up to almost 8 to 10 centimeter. And you can see in robotic surgeries, we had posted patients with bigger myomas because of the confidence of suturing much better. You can see the surgical time has been a little more in robotic surgery, but you can see the hemoglobin drop has not been there in robotic surgery. Estimated blood loss has been least. Post-operative hemoglobin has maintained, and vasopressin usage has been lesser. Hospital stay has been less than 1.5 days. So imagine the beauty of that. These are subserous and intramural fibroids. Even up to 18 to 25 centimeter fibroids have been easily removed. And these are patients who are 23 and 25-year-old young girls. So imagine when we are posting them for, fertility, how do we help them? Large centimeters is 18 centimeters, pseudo broad ligament fibroid. We're all worried because of the injury to the ureter. Easily done in robotic surgery because of its magnification of 10 times. And again, you can see how beautifully my assistants are resting with folded arms. Nobody is standing there. And you can see this fibroids, almost 6 big fibroids were there. And everything is under the control of the surgeon, where it has been beautifully been able to do it. So blood loss has been much lesser in these patients, lesser learning curve for surgeons, and age is no bar, and everybody can learn robotic surgery with a great ease and start working. Now, yet another problem with infertility patients is endometriosis. You all agree as a fertility person and laparoscopic surgeons that what a surgeon wants to do in an endometriosis and what we achieve are totally different things. And this gap, I will always say, is filled by robotic surgery because, like I just mentioned, today's patient, I got a reference where laparoscopic surgery was done, and many of the laparoscopic patients of endometriosis posted for laparoscopy gets converted to open surgeries because of the additions, because of not being cleared well. Otherwise, difficult, you do a laparoscope, drain the cyst and come back. In robotic surgery, we have never converted. The end results are better. And this is also substantiated by enough journals where they say confirmation is better, p-values are better, all substantiated by the sufficient journals. 10 times magnification, 3D imaging, less blood loss, lesser hospital stay, lesser wound infections. And again, one more international journal that we have published where we compared 38 robotic surgeries and 38 laparoscopic surgeries. All these patients either had previous LSCS or ovarian cystectomy done. They had dyspareunia, cyst as big as 6 to 8 centimeters, bilateral, unilateral. Stage 3 and stage 4 contributed to 20%. No bowel or bladder injuries, these patients. Hemoglobin maintained, drop of only 1 gram. Pain scores were excellent. And patient's hospital stay was 1.5 days. And imagine doing a laparoscopic surgery or even an open surgery for a grade 4 endometriosis, which is pelvic, it is invaded, infiltration into the bowels are there. So here also there was least injury to the bowel, except some serosal injuries. So we'll have to be very happy that grade 3 and grade 4 endometriosis can be dealt very well in robotic surgery. Least complications, better end results for these patients. Imagine bilateral endometriotic cyst, then somental additions are there. And this is one of my patients, elderly primary patient, where we had done endometriosis after robotic surgery, and this is less than 24 hours, how she's smiling and walking around. And these are the kind of results we can give for these patients. So it definitely has an advantage because of the lesser complications, better visibility, better excision, and lower complications. So again, substantiated by sufficient journals. And, I always say, we have the benefit of open surgery, benefits of laparoscopy, everything in smaller incisions, and good exposure is also there in robotic surgeries. Sacrocolpopexy is something again where we have patients with pelvic prolapses and they want to conceive. So even in these patients, you can do a sacrocolpopexy and go ahead with a pregnancy and results are much better. And we also see a lot of PCO patients, lot of obese patients coming in for fertility treatment. Even when these people need surgeries, we don't have to be worried because robotics is ultimate indication is for obese patients where a lot of people have advantage over robotic surgery, least complications, I would say lesser blood transfusion. This is one of my patients of 140 kgs. Imagine how she is walking beautifully. Again, all these patients are less than 24 hours. And can you see on the left side how at the less than 4 hours she's smiling? Imagine a patient smile like this at the end of 4 hours for severe endometriosis. And all these things can be learned by any surgeon, even if you start off today. It says less than 40 or 50 cases, you can be an expert in robotic surgery. So it's still not late for all my fertility doctors to switch on to minimal invasive surgery and start learning robotic surgeries, and we can give better results. When you are a fertility doctor and you operate, you know where to stop, how much to go, what to do when instead of relying on another surgeon is what we have to say. So we require for robotic surgery is because of its lesser pain, faster recovery, lower risk, shorter hospital stay, lesser scar, quicker action into normalcy. Though there are disadvantages because of its high cost, longer operating time, bigger spaces are needed. And, I've always said, though the disadvantages are there, it's definitely a boon for my patients and medical doctors so that we can give better results to our patients because of its physical ergonomics. And we have to practice ethically. Doesn't mean we have robotic surgery, we offer robotic surgery for everybody. We need to see whom is it indicated for. And definitely future is going to be robotic surgery and minimal invasive surgery. There are limitations of laparoscopic surgery. We need to understand that and choose it the right way. This was celebration for our 2000 as an institute from all our lab robotic surgeons. And this is my email ID. I will be open for anybody who wants to come as observers, want to do certificate courses for robotic surgery. So as a fertility specialist, I always like doing my own surgeries, be it myomectomy or endometriosis. And even in the era of IVF, we still do a lot of recanalizations for tubal recanalization, because of sometimes they would have lost their child. So tubal recanalization is still indicated in the era of IVFs, I would still say, and I support it. So I'm open to questions, anything. Please let me know while you're picking up the questions. This is how we enjoy in the robotic surgery, because you can see in the laparoscopy case, this is going on, especially when it is endometriosis, myomectomy, surgeon is screaming, assistants are all worried. You can see in my robotic surgery OT how my assistants are singing and enjoying. This is how the environment is in a robotic case, and this is a big myoma we had operated. And I think it is the era for robotic surgery. And this is one of our beautiful Kannada songs, and we all enjoy our robotic OT. I welcome each one of you to observe, come over as an observers to observe our infertility patients going through robotic surgery. Thank you. Thank you for this wonderful opportunity.
Thank you, Lavanya. From the talk, I can really understand how you enjoy doing robotic surgery. That's the crust of the whole talk. I should say that is the message that you convey, and all the youngsters will be really inspired hearing you.
Thank you, ma'am. All of you can also start off. You people are the youngest people, and very well, because you are so great at your anatomy, your pathology, your physiology. I think you will do more justice and become mentors.
True.
Thank you, Lavanya. It was amazing to see your presentation. And actually, it is making us that we should also learn at least the basics of robotics.
Yes, ma'am, definitely.
Age is not the number, it is just the number.
Yeah. And I think it is going to be, robotics is going to be there in every nook and corner. So, yes, definitely.
That's right.
Lavanya ma'am, being a radiologist, even I'm getting interested in robotics.
I'm more than happy. All of you can come in. All of you can come in.
And we are relieved because no, you can handle any surprise. Though we miss a fibroid, I think you can handle surprise in the theater.
Thank you. That is because you people like you will help us, map it so well, and we can see it through our third eye.
That was your kindled interest in robotics, ma'am.
Thank you. Thank you.
Thank you. I think if there are no questions, Lavanya will be leaving now because she has an emergency. So if you all have any questions, please put it on the chat box so that she'll be able to help you. Meanwhile, I think we'll get ready with Sridevi. I think all are just they're surprised with what they hear from Lavanya. They don't have any questions to ask because robotics is
I
new
hope
to
I
all
was
of
not
us.
too fast. I didn't want the other speaker to be wilting.
You were not fast, but everything is new, right? There was I would have been happy if you would have compared laparoscopy with robotic, so that we understand how good robotic would be when you do the same case in a laparoscopy. Anyway, good, very good.
I think Chennai, we will come and we'll post simultaneously one lap and one robotic surgery, and we can see it live surgery.
Okay, thank you. We'll do it. Good.
Thank you for the wonderful opportunity, ma'am.
We'll move on to the next.
Before AACOG Chennai, me and Chitra, we have organized a live robotic surgery from Chennai Apollo to Trichy.
Oh, that's so
that was
nice.
Sometimes some 10, 12 years back. Where that topic was the theme was like some modern technology saves life. So we thought we could relay that. And
ma'am, see, then you deserve the word. I said stalwarts like you both.
It was well appreciated because we had a lot of people who wanted to come and see what a robotic surgery would do. So it was a big success for us. Yes.
I'm sure. With you both around, I think everything has to be successful.
Thank you, Lavanya.
Thank you, ma'am. Thank you so much.
And Radhika Gauri has appreciated, and she has mentioned that we will line up in Kaveri for the next month to observe all of you operating, robotic surgeons.
Thank you, ma'am. Sure. We'll do it.
Shall we move on to the next one?
Yes.
Next speaker, yes. Sridevi's. Okay. We have Dr. Sridevi here. She's a consultant radiologist with experience of more than 20 years. And she has a passion for infertility ultrasound. And her images would speak what it is. You know, that you have to experience that to see, because I've been working very closely with her. I can tell you what it is. And, you know, what she would pick up on the image on scan, we could really see when we go ahead and do a laparoscopy. So that's what it has been my experience with Dr. Sridevi. And here we are to hear her, and she will tell us how you can really do a scan and get for yourself that image. So over to you, Sridevi. We are looking forward and listening to you talk on how useful would ultrasound be in an infertile woman.
Thanks a lot, ma'am, for your words. I don't know whether I deserve it. I would like to go with the basics, ma'am. What all points to be noted while doing ultrasound to get a good quality image? Everyone are able to see my slides, ma'am? My presentation?
Yes, visible.
Yes. Ma'am. So there are various modalities: ultrasound, MR, HSG, hydrosonography, hysteroscopy. But ultrasound, I think I'm not able to move the slides.
I have shared, ma.
I'm not able to move the slides.
Can you try sharing once again, ma'am?
Are you able to see?
Yes, ma'am. Yes, ma'am. Please make it
Now?
as full.
Now?
Yes, ma'am. Yes, ma'am. Double click on the slide, ma'am, so that it will move. Yeah.
Now you're able to see?
Yes, ma'am.
Sorry for the. Good evening, everyone, my seniors, friends, and colleagues. First of all, I'd like to thank the organizers, especially Chitra ma'am, for having given me this opportunity to be here. I'm here to talk about ultrasound and infertility. I'll take a little more time because I'm going to talk the basics and the advanced infertility imaging. So the various modalities are available. I'm restricting myself to sonography because it is indispensable, non-invasive, easily available, and less expensive. But the disadvantages are it is operator dependent. It depends upon the skill of the person who does the imaging. It is equipment dependent. This is very important because a low end or a mid range machine cannot give the quality image like that of a high end one. Chitra ma'am had given us the opportunity to work in S22 Expert and Logic 10. Maybe that would have given me all this skill to acquire a good image. And it is patient dependent also. Not depending upon the obesity, it depends upon the angulation, this the version and the flexion of the uterus. Because the anteverted and anteflexed will be easy, but anteverted and retroflexed uterus, it will be difficult to image. Even when you're doing an endometrial Doppler, you will not get Doppler's color signals when the angulation of the uterus is altered. So it depends upon the patient too. And adenomyotic uterus, it's difficult to image. And pulled up uterus, the post cesarean uterus, it is the most difficult one. We'll have the image depends upon depend on the patient also. So transvaginal sonography, the image optimization is very important to get a proper image. The scanning angle, it will be in the machine. You should make it to 360 degrees initially to screen the whole uterus and the ovaries and the lateral pelvic walls. Then you should adjust the scanning angle so that you restrict it to the image you want. That is, if you want to see the uterus, you just reduce the angle to the uterus level, then ovaries, and then the head nexa. So the scanning angle should be adjusted. For initial screening, it should be wide. After that, you should adjust accordingly. And the depth is also very important. In adenomyotic uterus, which is or in a post LSCS uterus, the fundus will be pulled up, so will not be able to image with the normal depth. We have to increase the depth till the fundus is seen and simultaneously adjust the focus. If you don't adjust the focus and if you increase the depth, you will not see the image. So when you adjust the depth, you should also adjust the focus and the gain accordingly to get a proper image. And wherever you see a pathology, do magnify it. Take some time to magnify it. Do not pan zoom it because the image quality will come down. You do a HD zoom. There will be a box. You put a box and then you zoom. The image quality will not come down and the pathology will be seen very well. Then the gain is sometimes what we do is we either increase the gain or decrease the gain too much. The gain, how should be set is the bladder should be anechoic. It should not be too black or too coarse. So according to the bladder echogenicity, you adjust the gain and then you image. After that, you don't adjust the gain. Because if you lower the gain too much, the internal echoes will not be seen. If you increase the gain, even a normal anechoic cyst will appear as if it has internal echoes. So the gain is also important. And the frequency, according to the patient, you should change. Because obese patients, we should decrease the frequency and you should image. Then systematic examination is very important. Your examination starts from the point when you insert the probe. So while inserting the probe, whatever possible, you image the vagina. If there is a distance between the vagina and the probe, maybe some lesion is there in the vaginal wall, maybe endometriotic deposits. Then look at the cervix, the uterus, endometrium. So systematically, while inserting the probe, you check for the sliding sign, the sliding organ sign, whether the ovaries are moving freely, the uterus is moving freely for endometriosis and all that. So your examination starts from the point while you insert the probe. Then the flexion and the version of the uterus, anteverted antiflex and retroverted retroflex is easy to image. We'll get a fine image, the fine endometrium and all that. But when the uterus is anteverted and retroflexed or retroverted and antiflex, really it's difficult and frustrating because we'll not be able to image the endometrium to the end, the triple line, the color Doppler signals, everything we will not get at all. So really it will be frustrating. Even a endometrial Doppler will take half an hour time for us. So then technical difficulties, most of the times or sometimes the ovary will not be seen. You would have seen in many reports, left ovary is not imaged or right ovary is not imaged. Maybe the bowel is overlying the ovary and is obscuring it. In that case, what you should do is you just put your hand on the abdomen, give a gentle press, move the bowel away, move the bowel air away. The ovary will come close to the probe. The resolution will be better. So this you can try, not always, but most of the time it has helped me. So ultrasonography in infertility, it's a workup for infertility.
பெருசா அது போட்டிருக்கோம் இல்ல அப்ப சின்னது கொடு சந்திரா அங்க போட்டு
Anything?
cream போடு அங்க இருந்து cream எடுத்துட்டா சந்திரா.
Others, please mute yourself.
Workup for infertility, then follicular monitoring, sonohysterography, and hycosi, that's contrast hysterosalpingography, and assisted reproduction techniques. So workup for infertility, it could be a cervical factor, uterine factor, tubal, ovarian. As you all know, I'll just be fast. Cover up. I'm talking over this. Uterine cause of infertility could be congenital or acquired. Acquired will be a synecdoche or polyp or fibroid or adenomyosis. Then, so the most important use of 3D ultrasound is the abnormalities of the uterus. Majority is the congenital anomalies of the uterus will be picked up in the 3D ultrasound. Because this anomalous uterus will affect either the embryo implantation or the continuation of pregnancy. So 3D ultrasonograph is now called as virtual hysteroscopy because it detects the abnormalities in more than 98%. 3D ultrasound can give you diagnosis almost in 90%, but still there are situations where we will have confusion between a septate uterus and biconvex uterus, which will be unsolved even after putting all the lines, curves and all that. We will have a confusion. At the time, we can go for a MR. So this is a figure of 8 uterus didelphys, the widely separated endometrial cavities, biconvex uterus. The closed cavities with the straight medial borders is the septate uterus and the arcuate uterus. So uniconvex uterus, what I want to say is when you always do your transabdominal scan before you start a transvaginal scan. Sometimes transabdominal scan gives us more information. When you put the probe, you will see the uterus is to one side. When you put a vaginal probe, you will not be able to appreciate the push of the uterus to one side. So when you do a transabdominal scan, the uterus will not be in the midline. If it is to either side, suspect a uniconvex uterus, either to left or right. Then there will be a single corneal projection. A beak-like projection will be there on one side. The other side will be normal. So only single conva will be there. 3D cavity shows a banana appearance. If there is a rudimentary horn, there will be hypoechoic shadow in the opposite side. So this is a unicornate uterus, banana-shaped cavity. Then fusion abnormalities, uterus didelphys, double uterus, and the bicornate uterus. Uterus didelphys is two separate uteri, cervix, in the midline or on the lateral pelvic wall. On transverse section, there will be a figure of 8 appearance. Bicornate uterus, two separate uterine bodies, but a single cervix. On transection, we will be able to see two endometrial cavities, two endometrial shadows, widely separated towards the fundus. So the external contour will show a dimple, and there are measurements where where we can differentiate a septate and a bicornate uterus in 3D. You just draw a line from the tips of both endometrial cavities and then measure the myometrium above the line, which will be less than 5 mm in bicornate uterus because of the contour, because of the dimple. So if the myometrium above the line is less than 5 mm, it is bicornate. If it is more than 5 mm, it is septate. Then Doppler, this is not yet proven, but if you put a color Doppler in between, since the myometrium is there in between, in the case of bicornate uterus, you will get the vascularity similar to that, the RA is similar to that of a myometrium. So bicornate versus septate uterus, there will be a dimple in the bicornate. The external contour will show a dimple in the bicornate uterus, but in a septate uterus, usually it will be convex and there will not be any dimple, or it can be flat. Then as I said, the line joining the tips of the endometrial shadow, the myometrium above the line will be less than 5 mm in bicornate uterus. It will be more than 5 mm in a septate uterus. Then the angle between the cavities, it will be more than 90 degrees in bicornate because it will be widely separated. It will be obtuse. In septate, it will be less than 90. And medial margins of the endometrial cavity will be convex in a biconvate, and it will be straight in a septate uterus. Here we are able to appreciate the medial margins is convex in a biconvate, whereas it is straight in a septate uterus. And this is a line joining the tips of the endometrial cavity. Since there is a dimple, that will be less than 5 mm. Here it will be more than 5 mm. The line is moved. Then how to differentiate a septate and a arcuate uterus? Both has a convex external contour. The angle between the endometrial cavities will be acute in the case of septate uterus. It will be obtuse in the case of arcuate uterus. And the distance between the line joining the tip of the endometrial cavity we have drawn. From there, we should take the measurement to the deepest point in between the two cavities. If it is more than 10 mm, it is septate uterus. If it is less than 10 mm, it is arcuate uterus. So this is the angle, arcuate and the subseptate. So as we all know, it has implications on the pregnancy, infertility, frequency of ectopic, abortions, premature deliveries, and dystocia. So to summarize, we should take a long section and the transverse section. In the long, after taking a long section, you see whether the uterus is in the midline or any of the sides. So if it's in the midline, okay. If it is in any of the sides, then see for the unicornate uterus. So then you see the banana sign in a 3D. If it is in the midline, you see, I'll take a transection and see whether the endometrial cavity is split into two or a single. If it is split into two, you see whether it is widely separated or close. So widely separated bicornate uterus, closed by is septate uterus. Then you see the shape of the cavity, then angle obtuse, it is biconvate, acute, it is septate uterus. Then line joining, as I said, if the line myometrium above the line is less than 5 mm, it is biconvate, more than 5 mm is septate uterus. Line joining the, and then deepest point between the two cavities, if it is less than 10 mm, it is arcuate. If it is more than 10 mm, it is septate. So this is the congenital part. In this, 3D helps us a lot to arriving at a diagnosis, but there are situations, even with Chitra ma'am, I had certain cases where we could differentiate biconvate and a septate. It was very close by. And in that case, I think we can go for MR. Even MR sometimes will not give a proper diagnosis. In that case, I think you have to do a hysteroscopy or a laparoscopy. Then acquired uterine abnormalities is endometrial or myometrial. Endometrial pathologies could be infective or adenomyosis, malignancy, synechiae, polyps, and submucous fibroids. So endometritis, acute and chronic. In acute, it will be thick and isoechoic endometrium. There will be alteration in the junctional zone and fluid within the endometrial cavity and increased vascularity. But in chronic, it will be thin, atrophic, avascular, and sometimes we will be able to see the calcifications. Then Sinake, these are hyperechoic bands traversing the endometrial cavity. This is very difficult to diagnose in a 2D ultrasound. We'll see only a thin endometrium. Otherwise, the hyperechoic bands, the restriction of the cavity is well seen in 3D ultrasound, and sonohysterography helps us a lot in diagnosing a Sinake rather than a 2D. Then comes the polyp. Either it can be focal endometrial thickening or focal masses within the endometrium, or diffusely thickened endometrium without discrete masses. Most of the time, this diffuse polyp will be reported as an endometrial hyperplasia or a thickened endometrium. It will be vascular. It mimics endometrial hyperplasia. Then we should look for a feeding vessel. A single feeding vessel will be seen if it is so suspect a polyp. In polyp also, sonohysterography helps us a lot. Here we are seeing a case of polyp. Here we are seeing a triple line, beautiful endometrium. She came for endometrial Doppler. So in one angle, this was a very fine endometrium with the color Doppler. Then in another angle, I could see a polyp, the feeder vessel. Then fibroid and adenomyoma, myometrial lesions, fibroid and adenomyoma. Fibroid, as you all know, it is a well-defined hypoechoic homogeneous and all that enlargement of the uterus, and it shows a peripheral vascularity. So submucosal fibroid, I want to share this because I want to tell you the importance of a transvaginal ultrasound and a 3D ultrasound. This is a trans-abdominal ultrasound where we are able to see a mass. Here we are able to see a mass. We feel that it is pushing the endometrium anteriorly rather than inside the endometrium. Then I did a transvaginal. Here we are able to see that there is a projection of myoma inside the uterine cavity, but not we are seeing majority of the fibroid is outside the cavity. But in a 3D, we are able to see almost 3/4 of the mass is within the uterine cavity. So this is how 3D helps us to arrive at a diagnosis. Transabdominal, then transvaginal. It helps, it gives some more information, and 3D gives us a lot more information. So this is the figure classification of the fibroids, type 0 to type 8. This is the type 0. This is the total intracavitary submucosal fibroid. This is more than 50%. What I showed was more than 50% is inside the cavity. This is less than 50% of the fibroid is inside the cavity. And this is the intramural. Intramural touch, this is close to the endometrium or touching the endomyometrial junction. This is totally intramural. And this 5, 6, 7 is for the subserosal. This is intramural. This is less than 50% outside the this subserosal. This is more than 50% is outside the serosa, and this is totally subserosal or pedunculated. Then hybrid type is nothing but it extends both subserosally and submucosally. 8 is cervical and other type of fibroids. Today I had a patient who showed all types of fibroids. There was one submucosal, one multiple intramural, one subserosal, and one hybrid. So she had all the fibroids in one. So I could image, I wanted to share that, but I couldn't do. At the end, I'll search for the image and I'll show you all the fibroids which I saw in that patient. So coming to adenomyosis, it is nothing but an ectopic endometrium. It's an invasive lesion with indistinct margins. It's generalized or focal. When it is focal, it mimics a fibroid. So there comes a diagnostic dilemma, whether it is adenomyoma or a fibroid. Then uterus may or may not be bulky. Not always the uterus should be bulky. Even a normal sized uterus can show adenomyotic changes. Then there will be asymmetrical myometrial thickening. We should measure the, if we have a doubt, we can measure the anterior and posterior myometrium, and we can see the asymmetry. Then probe tenderness. Most of the patients, they have adenomyotic patients, endometriotic patients, they have probe tenderness. Then there will be heterogeneous echogenicity. Linear striations will be there, like a rainforest appearance, and myometrial cyst, especially close to the junctional zone. Even a single cyst, they say we can brand it as adenomyosis. So adenomyosis, there will be disruption of the junctional zone. Early adenomyosis will not, sometimes the heterogeneity will not be well appreciated, but we take a 3D, we can see there is disruption of the junctional zone, echogenic flex at the endomyometrial junction, alteration in the myometrial. This I wanted to share that alteration myometrial echogenicity depending upon the phase of the menstrual cycle. So I think we can, if we have a doubt of adenomyosis, we can scan the patient in secretory phase so that the hyperechogenicity is best seen and we can easily diagnose the adenomyosis. So this is why sometimes we would have seen the patient last month, and this month we would have seen the patient again, but we would have done the scan in follicular phase, and this time we would have done the scan in secretory phase, and we will be surprised to see the differences. Last time it was so not much of adenomyosis, but this time it's showing too much. Maybe the secretory phase and the follicular phase imaging would have shown that difference. Not much difference, but there is. So as we plan for a 3D ultrasound, usually we do it in the secretory phase. We can do adenomyosis, the scan for adenomyosis also in the secretory phase. I think it will be easy for us to arrive at a diagnosis. Then color Doppler, increased vascularity and vascular clumps. Excuse me. Ma'am, I'll take a time. I'll just charge me.
I think as a gynecologist, all of us should be able to pick up this adenomyosis on ultrasound very easily, because we can fix both together, the clinical scenario that we see and what we see on ultrasound. So these features should be registered in all our mind when we see or look for in an ultrasound, when we do it on a routine transvaginal scan for anybody, and pick up this much easily. Yes, Sridevi, if you're there, you can go ahead.
I'm sorry for the interruption. Then the color Doppler, there will be increased vascularity and vascular clumps. No, there will be clumps of vascularity in certain places. That also indicates adenomyotic change. This is nothing but a junctional zone measurement. This usually is done in 3D maximum and minimum measurement, and we see the difference. It can be generalized or localized also. So how to differentiate a fibroid and a adenomyoma? Usually fibroid is well defined, adenomyoma is ill defined. Fibroid is homogeneous or sometimes heterogeneous if there is a degeneration or calcification. Adenomyoma is always heterogeneous, showing linear striations, that is rainforest appearance. Endometrium is well delineated in a fibroid. Adenomyoma, endometrium is not well delineated because of the altered echogenicity and the junctional zone disruption. Then hypoechoic rim will be seen. The capsule will be seen in the fibroid. No well-defined rim will be seen in adenomyoma. There will be peripheral vascularity with some central vascularity, but in adenomyoma, there will be penetrating vascularity. In a 3D, the junctional zone will be preserved in the fibroid. The junctional zone will be disrupted in the adenomyoma. A degenerated fibroid mimics adenomyoma. Adenomyoma in the follicular phase appears hyperechoic and mimics a fibroid. So coming to the ovaries, there are various types of cysts. So coming to polycystic ovaries, as I think everybody knows, usually it is done in second and third day of the cycle, more than 12 numbers, 2 to 9 mm. You should not, if there is a cyst more than 10 mm, you should not term it as a polycystic ovary. Not 2 to 9 mm follicles, more than 12 in number. Before it was a necklace pattern and all that. Here now it can be any type, generalized cystic pattern or necklace pattern or single or bilateral. Increased ovarian volume more than 10 cc. So polycystic ovaries, if it is ovoid, our ellipsoid formula, the routine, the 3 measurements will hold good for the volume. But if it is not ovoid, if it is irregular, this ocal imaging program is more helpful. We get 6 images in a 3D volume. If you get a 3D image, if you get 6, and then you have to trace all the images, and then the machine will calculate and it will give you a volume. that volume by Ockel is accurate. It holds good for the irregular ovaries. Then stromal volume, it's nothing but total ovarian volume. All this the machine will give. The machine has all the stromal volume, stromal index and all that. Total ovarian volume minus the total follicular volume will give the stromal volume. Then ovarian vascularity. But current evidence show no significant differences between the PCO and the control in the stromal volume echogenicity and the vascularity differences. So ovarian cysts, corpus luteum, endometrioma, dermoid cysts, serous and mucinous adenoma and carcinomas, endometrial tumors, and fibroma. Here, I know, though this is not much relevant for an infertility talk, I want to share this because future reporting will be in ORATS format. So we should be aware of what is ORATS, how it is being done, why it is done. Like BIRATS for breast, TIRATS for thyroid, LIRATS for liver, we have ORATS for ovary. So why they have brought this ORAT is the uniform interpretation should be there. There should not be ambiguity. And the ORAT 1, 2, 3, for each category, the management recommendations is there. So to streamline all this, they have brought ORATs for ovary. So before we were using all these common terminologies like complex cyst, mixed solid and cystic, predominantly solid, predominantly cystic. All these should not be used hereafter. They have almost stopped using all this in the reports. How you should report is either unilocular or multilocular. Even a single, more than a single locule will be multilocular. Unilocular with solid component or without solid component. Multilocular with solid component or without solid component. Then fully solid, that is more than 80% solid. This is how the report should be. Then color is, there is color scoring. Hereafter, I think if after few years, you will get a report as ORATS 1, CS1, ORATS 2, CS3. So ORATS 1 and 2, there will be categories, and I'll show you all the importance and the how we categorize this ORAT. Then the color flow is CS1 is no blood flow, CS2 is minimal, moderate, and strong flow. So it will be like CS4, strong flow. They'll report it as CS4. So it means strong flow. It directly goes to ORATS 4. So this is how the reporting is going to be, and they're streamlining it like this. So ORATS terminology, before we were using as all these in the left or the old terminologies, in the right or now it should be used like this. Follicular cyst is no more cyst, is only follicle. Corpus luteal cyst is corpus luteum. Mixed solid cystic complex, all these are either unilocular and multilocular with or without solid component. Then the cob web, fishnet, all those fancy names, all they have stopped, and it's only reticular pattern or hemorrhagic cyst. Straight away you can tell it is a hemorrhagic cyst showing a reticular pattern. Then for dermoid, tip of iceberg, dermoid mesh, all these should not be reported. It should be as hyperechoic content with shadowing either bone or teeth. Then echogenic lines and dots indicating fat. Then the ring of fire, increased internal vascularity, decreased vascularity. So all these should not be used. It will be from the color scoring 1 to 4. If it is no flow, color score 1, like that. 1. If it is strong flow, it should be color score 4. Then echogenic pure fluid, it's fluid containing internal echoes. Peritoneal deposits is peritoneal thickening or nodules. It should be reported in this way. So unilocular cyst, here comes the ORATS. Unilocular cyst, irregular wall, it straight away goes to ORATS 3. So papillary projection is there. If the number is 3, ORATS. Then multilocular cyst, irregular wall. Irregular wall straight away goes to ORATS 4. Solid, always irregular contour goes to ORATS 5. So solid is always 4 or 5. 4 or 5 is important to us. 1, 2, 3. These are almost 90%, 99% benign. 4 and 5, they show a high risk of malignancy. Here is the ORATS. The scoring will be like this. ORATS 0 is incomplete evaluation as BIRATS. ORATS 1 is physiological cysts like follicle, corpus luteum, and should be less than 3 centimeters. ORATS 2 is more than 99% benign and less than 1% risk of malignancy. ORATS 3 is more than 90 to 99% benign, low risk of malignancy 1 to 10%. ORATS 4 is more than 50 to 99% benign, moderate risk. And ORATS 5 is high risk of malignancy. It's almost more than 50% risk. So hereafter, I think the whole reporting system is going to change to ORADS and the color score. They will report a solid lesion like ORADS 5 with CS4 5. So it means it's a high risk of malignancy, solid lesion with strong flow in color Doppler. So this categorizes the lesion, and the management part. 4 and 5 will be seen by your on-course surgeon when the gynecologist, onco-gynac surgeons. And 1, 2, 3, I think this comes in the benign. 3 comes for a follow-up. So according to morphology, non-septated clear cyst, this is the cyst with internal echoes. Unilocular, thin-walled, anechoic, clear contents, no vascularity, unilocular cyst. If we see a papillary projection inside a cyst, if it is less than 3 millimeter, this is not a papillary projection or a solid component. If it is less than 3 millimeters, if it is less than 3 millimeters, you just mention as mild irregularities in the wall. It is not a papillary projection. Only if it is more than 3 mm, it should be reported as papillary projection, and the vascularity can be commented. Cyst with internal echoes. This is, I am showing 3 images. This is a corpus luteum, this is a hemorrhagic cyst, and this is the endometrioma. This shows a thick-walled cyst. So luteinized unruptured follicle. When you say a luteinized unruptured follicle is the follicle with thick walls, and you simultaneously see the endometrium, it will be thick and echogenic. So the cystic appearance will go off, and it will be replaced by a internal echoes, and this will no fluid in POD is unruptured luteinized follicle. Then hemorrhagic cyst, the classical reticular pattern. The echogenicity changes over time due to fibrinolysis of a clot. Sometimes it will be seen on one side. In that case, you can just move the probe and see whether it is moving. Then dermoids, as we all know, we have a thick wall echogenic material. Sometimes bone, teeth will be seen, and it will be avascular. Hyperechoic lines and dots will be there due to hair and fat. Then endometrioma, usually it is bilateral, 1/3 of the cases, thick shaggy walls with or without septae, ground glass appearance, probe tenderness, kissing ovaries. Kissing ovaries is an important clue for endometriosis. Both the ovaries will be seen in POD close to each other and close to the uterus. So this means some adhesions and endometriosis is there. Maybe the going into for a frozen pelvis. Then varying vascularity, sliding sign. Sliding sign is very important in the case of endometriosis. You just move the probe and see if the ovaries are adherent to the uterus, they will not move separately. Otherwise, the ovary will move separately from the uterus. So this is the sliding organ sign, tenderness guided approach. Now, while inserting the probe, you see the distance between the probe and the vaginal wall. If there are endometriotic deposits, you will be able to see. Then rectal water contrast imaging is also there. You can introduce water into the rectum and then put a vaginal probe and see the rectal wall, whether there is endometriotic deposits. Bladder wall imaging, whole abdominal screening should be done to rule out a hydrouretronephrosis and the abdominal wall lesions. Then 3D ultrasound for multi-organ involvement. Then comes the hydrosalpinx. It's nothing but a fusiform cystic lesion showing a cogwheel sign. The septum will be incomplete. In a cyst, it will be a complete septum. In a hydrosalpinx, we are able to see there will be incomplete septae, and sometimes tubular structure will be seen. So if you want to take the measurement, use the curved measurement and trace the measurement and then give it. So advantages of 3D is its coronal reconstruction is very, very important to diagnose a uterine anomaly. 360-degree analysis using a 3D probe. For uterine sinus K and the junctional zone assessment in case of early adenomyosis, 3D plays a vital role. Ocal, this is a reliable volume measurement. This gives accurate volume measurement for even for endometrium also. It gives accurate volume measurement so that you could plan your IVF. Then Sono AVC. This is mainly for follicle monitoring. When there are too many follicles, more than 20, it is really manually to counting is we will overcount or it will overlap. So this Sono AVC is very useful in that case. Sometimes this also does mistakes that it's omitting, it omits some follicles or includes some areas as follicles, but the error is not much. Then color flow mapping. For power Doppler, now we have vascularization index, flow index, then vascularization flow index and all that. For the perifollicular and the endometrial Doppler, we use all this. Then fibroid mapping, 3D will show, as I showed, 3D, it gives the exact location of the fibroid and how much it is projecting into the endometrial cavity so that you could plan your surgery. Then specific post-processing is available. You can just store the images in a 3D loop and then you can sit, then you can work on the images and you can give the reports. And it is time saving. It is readily available than MRI. And for sonohysterography and sonosalpingography, 3D plays an important role. So coming to the antral follicle count. So in infertility, we do an antral follicle count, which first we do a baseline ultrasound to rule out all the pathologies, what all we spoke so far. Then we look at the follicles. Good predictor of ovarian reserve and response to stimulation is the antral follicle. It's the best predictor of IVF outcome. It quantifies rather than quality of the follicle pool. It is a significant predictor of OHSS and ovarian hyperstimulation in IVF. Technique of measurement, usually it is done between 2nd to 5th day. Ideally, 2 to 6 mm size follicle should be counted, but practically this is quite difficult. So we take it as up to 10 mm. The largest follicle should not be more than 10 mm. It should be less than 10 mm. You count from outer to opposite margin within one ovary, then contralateral ovary, AFC count, total number is equal to the total AFC count. How we do is largest follicle more than 10 mm. What we do is measure all the large follicles in the decreasing order. Up to 10 mm you measure. Then you count all the follicles irrespective of the size. Then subtract the total number of follicles minus what you have counted the large follicles till 10 mm. You will get the antral follicle count when the count is more. If it is only 6 or 5, I think we will not have any difficulty in antral follicle count measurements. So antral follicle count, the number of visible ovarian follicles on day 2 to 3, less than 10 poor response, more than 22 is increased response. Ovarian volume, though this ovarian volume also, this can be done in ocal. So ovarian volume and the endometrial volume can be done in ocal imaging tool, and the volume less than 3 cc, it is supposed to be a poor reserve. Ovarian stromal blood flow can also be assessed, but not much of papers supporting this. Then sono AVC, this is nothing but a sono AVC. We are able to see the machine does everything for you. You just have to use the software. You just take the good quality image and then you can just with buttons, all these follicular coloring with the follicular size and the volume, everything comes in the decreasing order. So this is volume calculation by the computer. This saves your time. Then prediction of ovulation. This is very important in case of IUI. If you're planning for IUI, the prediction of ovulation is very important. The dominant follicle more than 14 mm, usually it grows 2 to 3 mm per day. The ovulation occurs between 18 to 24 mm. 2 days prior to ovulation, the RI is almost 0.5 or decreased. 24 hours prior to ovulation, there will be a halo around the follicle. Just prior to ovulation, the PSV and the flow increases. There will be a cumulus-like shadow. If all these are there, it's a prediction of ovulation. So this is more than 16 mm. Here we are able to see the perifollicular flow. Almost more than 3/4 of the follicle is surrounded by vascularity. Then this is the cumulus. On the day of HCG, if you are able to see the cumulus in all the three planes, I think it indicates I can proceed with the this indicates ovulation. So before HCG, what are the parameters you need to images? The follicular diameter should be at least 16 mm. The follicular volume should be between 3 to 7 cc. The perifollicular resistive index should fall. It should be around 0.4 to 0.48. The perifollicular PSV, this is very important. PSV is more than 10 centimeters per second. The follicular, certain machines only have all this. Follicular VI more than 6 and FI more than 35. This is vascularization index and this is the flow index, and presence of a cumulus. This is also very important. So timing of HCG is a key point for success of IUI cycles. So timing of IUI after HCG. If the PSV is 10 centimeters per second, the LH surge starts. Then PSV gradually increases and reaches 45 centimeter per second just before rupture. So timing of HCG based on the perifollicular PSV is very important. Higher the PSV, the earlier the follicle ruptures. So if you are seeing a follicle, if you are taking the vascularity and if you're measuring the PSV, if it is more than 20 to 25 centimeters per second, even double IUI helps, they say. One between 14, usually you do it, I think, between 30 to 36 hours. If the PSV is little higher, I think you can do one between 14-16 hours and the other between 34-36 hours, because if the PSV is higher, the follicle ruptures earlier. Then coming to the endometrium, the endometrial grading is very important. So what are the prognostic parameters for pregnancy? Endometrial thickness between 8 to 13 mm is favorable. Either less than 6 or more than 15 mm is unfavorable. More than the thickness, the pattern is very important. Triple line is highly favorable. Homogeneous hyperechoic is unfavorable. Endometrial volume between 1 to 2 ml is unfavorable. Endometrial volume, we should use, you should do it with the OCAL. That gives the exact, the routine measurement with the ellipsoid formula, it overestimates the volume. So using the OCAL, if you take the volume, it will be accurate. So 2 to 3 cc, 3 to 5 cc, 5 to 7 cc, all this, according to the volume, the pregnancy percentage increases. Coexistence of a thin and a not triple line EM is highly unfavorable. So abnormal endometrial patterns will be premature secretory endometrial pattern. Sometimes we see a thick endometrium, fully filled up endometrium, then tiny calcifications in the endometrium, then fluid within the endometrial cavity. All these are unfavorable for pregnancy. Then coming to the endometrial Doppler, usually we do it for IVF cycles. We can do it even for IUI cycles too. We can assess the endometrial vascularity. So I think everyone knows zone 1, 2, 3, and 4. 4 is inside the endometrial cavity, and the zone 3 is the internal endometrial hypoechoic zone, and zone 2 is the hyperechoic endometrial edge, and zone 1 is the myometrium surrounding the endometrium. So all these zones will show vascularity. So when you're doing endometrial Doppler, if the endometrium is, we report it as type A, B, C. Type A is triple line, B is slightly triple line. Sometimes we'll see a triple line, but it will not be as good as the proper triple line. Type C is thick and echogenic endometrium. Then color flow, 3 consecutive good waveforms you should take, and then you should take the measurement. Group A is no endometrial flow. Group B is subendometrial flow. Group C is both endometrial and subendometrial flow. So what are the favorable factors coming to endometrium and IVF is endometrial thickness between 8 to 13 millimeters, endometrial volume between 3 to 7 cc, endometrial pattern triple line, endometrial growth 1 to 2 mm per day, endometrial vascularity between RI between 0.6 to 0.8 and PI between 1.1 to 2.3, endometrial contractions pre-ovulatory 3 to 4 per minute, uterine artery Doppler, PI should be less than 3.2. If PI is more than 3.3, almost no pregnancy in IVF. I've seen a few cases where we have given uterine artery Doppler PI as 3.5, 3.8. Those patients, they have failed to conceive in IVF cycles. So then coming to the endometrial vascularity, absent subendometrial and endometrial vascularity on the day of HCG, this is the predictor of failure of implantation in IVF, irrespective of the morphology of how good the endometrium may be. The endometrium will look so good with the triple line and all that. If there is no endometrial, subendometrial vascularity, there will be failure of implantation in IVF. Then pregnancy achieved in the absence of, though the patient getting conceived, in the absence of endometrial and subendometrial flow on the day of embryo transfer, most of the pregnancies, they end in spontaneous abortion. Then comes the sonohystrography. Then the patient should be in the lithotomy. It's very easy. Patient should be in the lithotomy position. 6 French Foley catheter is inserted. The balloon is with 1.5 to 2 ml fluid. The balloon within the cervical canal. 5 ml normal saline is 1.5 to 2. Balloon is distended with 1.5 to 2 ml fluid. The balloon should be within the cervical canal so that it doesn't come out. Then inject 5 ml normal saline to distend the uterine cavity. We will be able to see all the pathologies to a surprise: tiny polyps, fibroids, and the synechiae. They'll be very well seen. The speculum is removed. Then the TV probe is introduced along with the catheter in situ. When we inject a normal saline will be anechoic in ultrasound. It's a negative contrast. If you use a contrast, usually it obscures the echogenic lesion. So we don't use contrast for a sonohistography. We use contrast only for sonohysterosalpingography. Or sometimes we mix air bubbles with the normal saline and then we inject. The movement of air bubbles will be well seen. But the contrast, if it's available, SonoView, these cost around, I think, 5,000, I think. So if it is available, it will be best to diagnose for tubal blocks, for sonosalpingography. So sonohistography, what does? It improves the delineation of the uterine cavity. Saline is used as contrast. Compared to hysteroscopy, HSG has 87% sensitivity and 100% specificity for the detection of uterine cavity abnormality like polyp, fibroid, and adhesions. So tubal patency, sonosalpingography, it is a OPD procedure, less time consuming, cost effective, non-invasive, no anesthesia, no radiation, no contrast. It is reproducible, reliable. What are the disadvantages? There will be tubal spasm. The hydrosalpings, it will be already it has fluid inside. So it gives a tubal flow, false positive for patency. Then technical skill is required. The exact site of block cannot be located. Will not be able to locate the site of block. But gold standard is HSG. Sonosalpingography gives us almost 80% of the diagnosis. But what all we cannot see is the exact site of block we cannot see. Intratubal pathology cannot be detected. Peritubal adhesions, tumoral motility cannot be assessed. And it is more of subjective. Only we see and we tell there is spill. But HSG, it has the recording. That is the gold standard. So in ART, monitoring of ovarian response, prediction of ovarian response in pregnancy, oocyte retrieval, embryo transfer under ultrasound guidance. So what are the ultrasound guided procedures? Sonohysterography, sonosalpingography, cyst aspiration, hydrosalpinx aspiration, ascitic fluid aspiration on OHSs, oocyte retrieval, and embryo transfer. So ultrasound guided embryo transfer, here I'm not talking about oocyte retrieval, but ultrasound guided embryo transfer, this is very important. So we have assessed the patient, we have seen the endometrial Doppler, we have seen the good embryos, we have taken the good embryos, we have assessed the patient is fit for embryo transfer, everything is fine. But the transfer of the embryo is very, very important. Where we transfer it, how we transfer it. So placement of catheter is very important. The catheter, the external catheter should be beyond the internal os. Then the internal catheter, direction of catheter, for what all the ultrasound guidance is used for placement of catheters, then you should say you're inside the internal os, stop where you stop the external catheter till then you advance the internal catheter. Then the internal catheter is inserted. We can image the direction of catheter along the contour. We can just ask them to adjust the speculum just above, below, to make the cavity straight with the ultrasound guidance along the contour of the endometrial cavity. It prevents the damage to endometrium and plugging of the catheter. Even coiling of catheter can be seen. They will be inserting, but we will not be able to see the catheter in the image. So it means the catheter is getting coiled. Sometimes the catheter goes into the false passage. That can be seen with the ultrasound guidance. Then we are doing it with a full bladder. So it straightens the uterocervical angle and ease the catheter passage. Negotiate the catheter through difficult cervical canal. This is also very useful with the ultrasound. Then correct position of the catheter tip. This is very, very important. You have done everything. The placement, the placement of the catheter. If the catheter tip touches the fundus, they say the pregnancy rate comes down. So the catheter tip should be positioned exactly. There is a measurement where we draw the line along the uterine corners and then we take the midpoint and there we transfer. Usually we don't exactly measure. We take around 1 centimeter from the fundus and then we transfer the embryos. Factors affecting implantation rates are the ease of transfer, presence of blood or mucus on transfer catheter, coiling of catheter, the type of catheter used, catheter loading, technique of transfer, uterine depth and angulation, precise depth of ET in uterus, avoiding uterine contraction, maximum implantation point. What I said was that we have to calculate the maximum implantation point. All these factors, they affect the implantation rates. I think this video is not uploaded. It's not shown. So finally, carry home messages. Trans-abdominal screening followed by transvaginal screening is a must. Systematic examination should be done, and all the optimization of the imaging should be done before you do an ultrasound. Baseline scan to rule out all the pathologies, antral follicle count. 2D and 3D ultrasound is a must for all infertility patients. Your scan should not be complete without a 3D ultrasound. So for all the patients, you do a 3D ultrasound. This would give some information to you. Proper follicular study, proper pre-HCG parameters, proper IUI timings, all these increase the outcome of IUI and avoids IVF in certain patients. Not always, and not in all patients. In certain patients, I think if we follow all this, we can avoid IVF and the IUI success rate will be more. Then OCAL. OCAL for accuracy of the volume measurement. Sono AVC is time saving and easy tool for multiple follicle counts. Then color flow. Color flow is booming up now. You all should learn the color Doppler imaging. You should see the perifollicular color flow. You should not stop with seeing the follicle, the size and all that. You should do a perifollicular color flow study. You should take the PSV measurement. You can just very easy to assess the PSV. If it is what I said was 10 to 45 centimeter per second, you can plan your HCG, plan your IUI, and you can increase the success rate. Then endometrial Doppler, not only for IVF, even for IUI patients, you can do an endometrial Doppler and assess the receptivity. Then uterine artery Doppler, this I have myself experienced in many cases. If the uterine artery Doppler shows a PI of more than 3.5, 3.2, most of the 90% of the patients, they didn't conceive. Then VI, FI and VFI, if available, should be used wisely. Sonohysterography is promising. A proper ultrasound guided embryo transfer, it has a great impact in the rate of conception. Thank you, everyone. I hope.
Yeah, thank you. Thank you, Sridevi, for that exhaustive lecture. I know the use of ultrasound in any gynecologist practice is inevitable, and we get so much of message after doing an ultrasound. So your lecture would be useful for all of them who have been listening to it really. So thank you very much for that. Any questions? Then if it's on the chat box, if you can answer, it'll be good. Let me just see. Somebody has asked for how will you measure junctional zone on day 3, any particular day?
On 3D.
On 3D and any particular day.
Usually 3D scans are done in the secretory phase because the endometrium they'll be well seen only in the secretory phase. You should take a 3D, you should see the endometrium. As in other cases, the endometrium will not be well seen in adenomyosis. It will be difficult. That will be disruption. I think if I have the image, I can show you. Usually done in the secretory phase, the endometrium should be thick. The zone, the hypoechoic zone around the endometrium will be seen. But in the case of adenomyosis, there will be endometriotic infiltration will be there. So that junctional zone will be disrupted and it will not be well seen. That hypoechoic zone will not be well seen in the 3D.
Differentiation between the myometrium and endometrium will be very difficult. It will be diffuse. So you will not be able to appreciate that.
So that will be
Then
the junctional zone.
how to measure the thickness, madam? They say above 8 mm it is bad prognosis when we are going to plan for IVF. So measurement of that hypoechoic zone should be done, is it?
Yes.
No. It is not about
thickness.
For IVF. It's not about for IVF. It is to diagnose adenomyosis. That's it. That will not have an impact on the IVF cycles.
It is not only for diagnosis.
It is for prediction also.
Implantation, it is very important.
Yeah.
Because normally we say more than 12 or 13 adenomyosis. But if the level junction zone thickness is only less than 8 or around 8, conception will be there. 8 to 11, there may be, but the miscarriage rate is again high.
So
Okay,
that
ma'am.
measurement is the measurement of that hypoechoic line.
Hypoechoic zone, junctional
Yeah.
zone.
Oh.
When you look for the 3D, 3-line pattern, no, Victoria.
Yeah,
Even
yeah.
at that time you can see, no, you will see.
Yeah, yeah.
that-
There'll be a hypoechoic.
So if you just check on that, even that you will know. You will
Junctional
even
zone
with-
is nothing
with
but
first-
endomyometrial junction. ma'am.
Junction.
Endomyometrial junction.
Yeah.
So that endomyometrial junction will be hypoechoic, uniformly hypoechoic in a non-adenomyotic uterus. So if there is adenomyosis, there will be endometrial invasions will be there. So it will not be uniform. In some areas it will be thin, some areas it will be thick. So in that case, you should take a measurement, and the difference. Now, what I showed was the difference you should calculate and you should predict. Ma'am.
Okay. And what about uterine volume? That is also on 3D. Measurement of uterine volume.
Endometrial volume.
No, uterine volume as it is.
Uterine volume, we need not have a 3D, ma'am. Even in a 2D, we can very well measure.
Okay.
Like how you will do the ovary, you can do the measurement on
All
that
the
also.
3 dimensions.
Yes, ma'am.
Yes.
ma'am.
Okay.
Usually ovaries and ovaries only we do it with focal, endometrial volume we do it with the focal with the 3D. Otherwise, uterine volume as such we can do it in a 2D.
2D.
Okay.
Ramani, your input on ovarian uterine volume. See, Victoria is asking about uterine volume.
Yeah.
Ramani.
Uterine volume, normally we expect the uterine volume to be around somewhere between 70 and 80.
70.
Okay, 70 and 80 acceptable
80.
in a multiparous. But in patients with adenomyosis, I would like to have the volume of the uterus less than 100 ml.
Minimum.
That is always ideal. But அது வந்து sometimes வந்து if we have a pre GnRH level of 200 it will not reduce.
It will not come to less than
Come
100.
down. But we have had patients ஒரு 140 குக்கெல்லாம் கூட implantation வந்திருக்குது, டெலிவரி பண்ணிருக்குதுங்க.
And isn't the junctional zone thickness more important than the volume? If the
இல்லம்மா, junctional zone thickness is very important, but volume is also equally important. நீங்க என்ன பண்ணுங்க, அதுக்கு வந்து you have to put the patient after embryo transfer combined with letrozole, GnRH, preferably Zolodex plus norethistidine.
Yeah, that's what we have discussed.
அது வந்து 3 monthsல இருந்து 6 months வரைக்கும் you can give them. So கண்டிப்பா குறையும். 3 monthsல போட்டீங்கன்னா vascularity குறையும், அந்த myometrial vascularity இல்ல, that also comes down, and definitely the endometrium becomes very much thinned out. So without giving a break for a bleeding, you start the patient on FET cycle க்கு estrogen போட்டுடுங்க.
So 3 to 6 months.
ஆமா, it depends upon the original volume. Actually, one patient was referred to me for adenomyomectomy. அது வந்து ஹியூஜா இருந்தது, 5 centimeters by 5 centimeters. பட் நான் சரி ட்ரை பண்ணி பார்க்கலாம், வரலன்னா பாத்துக்கலாம்னு சொல்லிட்டு I just gave her Lupride வந்து I think Zolodex I gave her 5 doses. Then it was thinned out, and then we started the estrogen அப்படியே ஸ்டார்ட் பண்ணி I sent her 9 mm வந்தது. 9 mm beautiful flow எல்லாம். So don't allow for withdrawal bleeding to happen.
Okay.
வரவே கூடாது. withdrawal வராம பண்ணாதான் results will be good. Both topics, both speakers have done their job excellent.
Very exhaustive and
excellent
topic.
Useful,
very useful.
Thank you very much. Shall we close then?
Yes, Chitra.
Thank you, Sagati, for this support, and thank you. I thank all the audience for being with us till the end of it. Thank you.
Thank you, ma'am.